Hi, and welcome to our presentation on therapy comparison in adolescents with anorexia nervosa. I'm Sydney Green.
I'm Isabelle McGreevey.
And I'm Brynn Walker.
And we're excited to share our presentation with you today. Our PICO question is, in adolescents with anorexia nervosa, does family-based therapy result in more effective recovery than cognitive-based therapies? So before we begin the research of the project, it's important to understand the background of the disorder. The age range of the adolescents researched were between 12 and 25 years old. According to the National Institute of Mental Health, anorexia nervosa is a significant, persistent reduction in food intake, leading to extremely low body weight for the context of age, sex, and physical health. Adolescents with anorexia nervosa are at a higher risk for future physical and mental health conditions, shown by the statistic that anorexia nervosa has the highest mortality rate of any mental disorder. The U.S. Department of Health and Human Services states that eating disorders such as anorexia nervosa are diagnosed in almost 3% of adolescents aged 13 to 18. Anorexia is a complex disease process, and according to the Cleveland Clinic, it requires the need for a multidisciplinary approach involving psychotherapy, nutrition counseling, and possible inpatient or outpatient medical care. Two of the most commonly used methods in treating adolescents with anorexia nervosa are family-based therapy and cognitive-based therapies. According to Cockey and McCann, family-based therapies focus on involving the entire family in the patient's care, while attempting to restore the weight of the child and bring up psychosocial issues as a family. This is done in 3 stages, with the first stage including family meals, the second bringing up issues to be discussed as a family, and the last stage focusing on issues specific to adolescents, such as autonomy and boundaries. All 3 stages focus on weight gaining. For this project, we will use FBT as the abbreviation for family-based therapy. Cognitive-based therapy is abbreviated as CBT, focus on modifying the thought patterns and include cognitive behavioral therapy, cognitive remediation therapy, adolescent focus therapy, and enhanced cognitive behavioral therapy. There are also 3 phases in cognitive-based therapies. The first phase focuses on changing the mindset of the adolescent. The second targets the changing concerns that surround weight and shape. And the third phase finds ways to maintain treatment and keep up with the changes while finding ways to deal with setbacks in therapy. Many of the therapies use both body mass index and the eating disorder examination score to determine the efficacy of the treatment modality. The eating disorder examination score, otherwise known as the EDE score, comes from a self-reported questionnaire completed by the adolescent, examining, quote, a measure of the range and severity of eating disorder features, end quote, including topics such as eating concerns, shape concerns, weight concerns, and restraint ability in regard to eating behaviors, according to the Child Outcomes Research Consortium. A decrease in EDE scores shows an improvement from baseline. According to the National Heart, Lung, and Blood Institute, body mass index, otherwise known as BMI, is the measurement of body fat percentage compared to the height and weight age appropriate for the group. An increase in BMI shows an improvement from baseline.
So now that we understand the background, we're going to look at the different studies that we use for this project. So the first study was called a randomized control study of cognitive behavioral therapy and behavioral family therapy for anorexia nervosa patients. It was written by Ball and Mitchell and published in 2004. This was a randomized controlled study comparing the effectiveness of CBT compared to behavioral family therapy, or BFT, for adolescents with anorexia nervosa in an outpatient setting. It had 18 female subjects who were between 18 and 23 years old. They received 25 therapy sessions in either CBT or FBT over the course of a year, and their EDE scores, BMI, and weight were used to determine outcomes. Ball and Mitchell found that 77.8% of subjects in both groups increased their body weight to within 10% of normal for their age. BMI centiles increased for both groups, but more so for the CBT group, and EDE scores also decreased for both groups, but more so for the FBT group. But despite these slight differences, the authors concluded that overall they could not determine which therapy method was more effective. Some limitations to this study included how long ago it was published, the small sample size, and only studying females. The study also lacked a lot of detail on what exactly was involved in each therapy intervention, which would make it very hard to replicate the study.
The next study we looked at is titled Randomized Clinical Trial Comparing Family-Based Treatment with Adolescent-Focused Individual Therapy for Adolescents with Anorexia Nervosa. It was written by Locke, Lagrange, Agris, Moy, Bryson, and Joe, and it was published in 2010. This was a randomized control study to compare family-based treatment to adolescent-focused therapy, otherwise known as AFT. Subjects were between ages of 12 and 18, and there were a total of 121 participants. 91% of these participants were female. Each of the participants was assigned a therapist to either FBT or AFT. Subjects participating in FBT had 24 sessions, each an hour long and over a time span of a year as they worked through the 3 phases of family-based therapy. AFT subjects attended 32 sessions, 45 minutes in length over the course of a year as they worked through the 3 phases of adolescent-focused therapy. Locke et al. Reviewed the subjects' body weights and EDE scores at the end of the trial and at 6 and 12 months later. The researchers found no statistical significance between the 2 methods at full remission rates at the end of the trial, but at the 6 and 12-month follow-up, FBT had higher rates of full remission. At the end of the trial, FBT also had higher partial remission rates, a higher BMI gain, and a lower EDE score than AFT. Some of the limitations of this study include that the study was published 10 years ago, the small sample size, and the recruitment of the participants was from those who had already received treatment in the past. There was also a lack of follow-up study after 12 months, a large sample of female participants with lack of males, and the fact that 50 of the participants continued treatment after the treatment concluded in the study could have affected the outcomes.
Because of the lack of comparison studies that we have available for this topic, we also looked at 4 studies examining either CBT or FBT. The first of which was a research article titled Enhanced Cognitive Behavior Therapy for Adolescents with Anorexia Nervosa, an Alternative to Family Therapy by Dalle Grave et al. This is a level 4 evidence cohort study published in 2013 in an eating disorder clinic in Italy. The aim of this study was to provide specific data to understand enhanced cognitive behavioral therapy, CBTE, and see if it would be a valuable alternative to family-based therapy by completion rate, effective outcomes, the changes maintained, and it did not compare the 2, however. The lone intervention was 40 sessions of CBTE over 40 weeks with a follow-up 60 weeks later. The sample included 46 participants who were white females between the ages of 13 and 17. Measurement criteria included assessment before, immediately after, and 60 weeks later using BMI centiles and EDE scores. Dalle Grave et al. Found that the global EDE score decreased by 2.03, and there was an increase in weight among the 29 treatment completers. 32.1% of CBTE participants gained enough weight in order to reach the expected weight for their age and sex. At the 60-week follow-up, very few required other treatment, and 4 more patients reached 95% of their expected weight for age and sex, resulting in 13 out of 29 total patients reaching that criteria. There were definitely significant limitations, such as all the subjects were white and female, there was a high dropout rate, the data was from 2013, and there was no comparison to family-based therapy because it was a cohort study getting baseline information on CBTE. The sample size was also small and from one clinic in a specific region of Italy. The next cognitively themed research article was a level 4 cohort study from 2015 titled Time to Restore Body Weight in Adults and Adolescents Receiving Cognitive Behavioral Therapy for Anorexia Nervosa by Carroll et al. This study was done to see how much treatment was needed in adolescents and adults with anorexia nervosa treated with outpatient enhanced cognitive behavioral therapy in order to restore body weight, and only the adolescent results were focused on. The CBTE treatment involved 40 one-to-one treatment sessions over 40 weeks with a review session 20 weeks after completing treatment. It used BMI centiles and EDE scores to measure outcomes. Of the 46 adolescents who participated in the study, 34.7 did not complete treatment. According to Carroll et al. 2015, quote, eating disorder and psychopathology had significantly improved, end quote, with a decrease in average EDE score and weight improving as well, since 32 adolescents reached the centile that corresponded with their age after treatment. 96.6% of them maintained this weight. The mean time in order to restore body weight was faster in adolescents than adults at 14.8 weeks. Some limitations this study brought included, again, the small sample size, the high dropout rate, the gender bias, and the fact that it did not compare exactly to FBT in order to answer the PICO question. Also, for this specific study, weight and the time it took to restore that took priority over all other aspects of anorexia nervosa, and remission does not just focus on rate.
So the next study we looked at was called Inpatient Cognitive Behavioral Therapy for Adolescents with Anorexia Nervosa, Immediate and Longer-Term Effects. It was written by Dalle Grave et al. And published in 2014. This was a cohort study aiming to determine the effects of an inpatient program in Italy based on CBTE for adolescents with anorexia nervosa. 26 subjects participated in an inpatient program immersing them in 24/7 CBT environment for 13 weeks, and then they had 7 weeks of outpatient CBT once a week after that. The subjects were recruited by healthcare providers and had to be between 13 and 17 years old. All of the subjects were white and only one was male. The researchers found that all 26 of the subjects did gain weight, 25 out of the 26 increased BMI centile, and 40% decreased their ADE scores significantly. These results remained stable at 6 and 12-month follow-ups with only slight decreases for some patients. The researchers' main conclusion was that inpatient CBTE is an effective treatment for adolescents with anorexia nervosa. The limitations present in this study included that it did not have a comparison group of FBT patients, and that some of the subjects received outside treatment in the follow-up period, which may have influenced the results. Also, all of the subjects were white and only one was male.
The final study we looked at is titled Open Trial of Family-Based Treatment of Anorexia Nervosa for Transition-Age Youth. It was written by Dimitropoulos, Landers, Freeman, Novick, Garber, and Grange, and was published in 2018. This is a cohort study done to look at the family-based therapy for transition-age youth and its efficacy. These transition-age youth are between 16 and 25 years old. There were initially 26 participants. However, 12 dropped out of the trial, leaving 14 remaining participants. From the initial group, there was only one male. However, it's unknown if he was one of the final 14. These participants went through the 3 phases of family-based treatment with 25 sessions, 50 minutes each at varying times depending on the phase of the treatment they were in. The study also included a 20 to 30-minute individual session for the participant before each session of family therapy. To measure progress, researchers calculated BMI and EDE scores at baseline, end of trial, and 3-month follow-up. Researchers found that the participants' BMI had increased and their EDE scores had decreased at both the end of the trial and 3-month follow-up, both showing signs of improvement from baseline before receiving treatment. Some limitations to the study included the incredibly small sample size, the lack of male participants, the lack of follow-up past 3 months, the fact that weight at the 3-month follow-up was self-reported by the participants, and that the study did not have a comparison therapy with an alternative treatment to family-based therapy.
So after looking at all of these studies, we have concluded that overall, the articles suggested that family-based therapies and cognitive-based therapies have comparable outcomes. Thus, we did not find the answer to our PICO question. Because there just really hasn't been much research on this topic, there really needs to be more up-to-date and extensive comparison studies before a definitive answer can be given. We did learn that anorexia nervosa treatment is difficult to study due to the unique presentation of the disease in each individual patient and the specific needs that each patient may bring to a therapist. So we're hoping that researchers continue to find innovative ways to study therapies for this condition so that we can find out what works best. Another important conclusion was that almost all of the research suggested that the family should be included in treatment in some capacity, even if the treatment isn't labeled family-based. Many of the CBT therapies also included the family in some way, and it seems generally accepted that involving family members was important. So that's one conclusion that we were able to come to, even though our question remains unanswered.
Although the research process was difficult, the answer to the PICO question that was wanted wasn't found, and there are still important factors that we can apply to nursing practice. For one, nurses can use this information to ensure that each individual adolescent patient who is suffering from anorexia nervosa finds the proper treatment that keeps them the healthiest, whether it be cognitively based, family-based, or elements of both. Also, nurses can advocate for more research into the field of eating disorder treatment to find definitive answers on best treatment practices to recommend to patients. Another key application to practice is that nurses can understand the importance of including the entire family of the adolescent with anorexia nervosa in any needed medical treatment whenever possible, and encouraging the family to be involved with therapy. It may be hard to find data on and study anorexia nervosa because of its complexity and severe effects if not treated properly, but even just by knowing the different treatments out there that are effective more individually or on a family level can create a change to nursing practice that can be beneficial and aid in remission for all adolescent patients facing that difficult and unique battle that is anorexia nervosa. Thank you.